Don't get caught in the mosh pit. Fuel to the fire, ain't nobody can stop it. Trouble in my city, but you know I'm across it. Got a 40 on my hip and I'm liable to spark it. Throw down these hits, my click is indivisible. I aim, you duck, I squeeze, now you invisible. I'm not afraid of getting physical. All these different chemicals are fogging up my visuals. Bloods on my hands, got slugs on my gunners. Yo, we notorious, we ain't no runners. Bloods on my hands, got slugs on my gunners. Yo, we some warriors, they ain't called gunners. Bloods on my hands, got slugs on my gunners. Bloods on my hands, got slugs on my gunners. Put on my sweat, put on the beat, put on the map, put on my team. Take out every motherfucker in between, know what I mean? Better myself, better my aim, better my rap, better my name. Killing rappers on my hang, I'm by their chains for the fame. Never thought I would it, now I'm running. You don't wanna follow me, I'm up in front of.
What's going on? What's going on? Good evening and welcome to Steve the Kidney Nurse. What's going on out there? Hope everyone's doing well. Let me tell you something. Share this broadcast. This is one show that you need to be tuned in. Right now, I only got one person watching, but that's okay. Knowledge is power. And let me tell you something. This show tonight about involuntary discharge, a dialysis patient, if you on kidney dialysis, your parents, your loved ones, you can find yourself in this position. Okay, now what started this show tonight? Young lady on TikTok, I stitched her video. She couldn't have been no more than 30 years old, okay? And she was on the transplant list and she said her medical team dropped her. She's in a desperate need for a living donor, okay? Now, a lot of people, when I did the stitch, they commented, they wanted to know what could have prompted for them to drop her. I want to know what could have happened. It could have been anything, but what the young lady mentioned has a malpractice suit against the surgery team for injury during surgery. Now, she has a legitimate complaint, okay, to do that. And so now, legal probably say we got to, probably consulted the doctors. They probably consulted legal, say, well, now that there's a malpractice suit pending, we're going to have to drop this person as a patient. All right. Now, when you do that, technically, the nephrologist, they're supposed to find another clinic, right, for this person. You're not supposed to leave that person in limbo or have them go to the hospital or more or less not have anywhere to go. we know that chronic kidney failure is a serious disease. Over 600,000 people deal with this condition, okay? And we know when this progresses to end-stage renal disease, dialysis is required to sustain life. Now, over 1,000, many of you may not know that, over 1,000 dialysis patients are involuntary discharged each year. Some of them may find other facilities. Some of them go to the hospital. And some of them pass away. This is almost close to murder. Whatever happened to the doctor's oath? First, do no harm. Whatever happened to that? Now, let's look at some of the reasons for involuntary discharge, right? And some of the percentage rate. Treatment non-adherence. Maybe the person's not following the guidelines of their treatment prescription, meaning somebody may always get off dialysis before their time is up. They may not show up every treatment. Okay? That's what they're talking about. When I worked in dialysis, 30-chair unit, all right, we had patients that didn't show up almost close to 30 days. They still urinated, they caught on to the game, and they didn't come until that last minute. And the clinics got tired of that. Okay? And so what they want to do is put you on a contract, and if you break that contract, then they have a right to discharge you. But that's not happening anymore. So let's look at some of the reasons again. Like I said, treatment non-adherence, that's 25%. Verbal threats. All right, somebody threatened the staff or a patient, 8.5%. Lack of payment, 5.2%. We know insurance pays. Combination verbal physical threat, 5.2%. And verbal abuse, 5%. Okay. So what do we do? This should be the last resort of involuntary discharging someone, because we know if you involuntary discharge someone, whether they had a legitimate complaint or it was verbal threats or whatever, that has blacklisted them to all the other facilities in the vicinity. Now, patients have to go to the hospital if they can't find a clinic. In the hospital, you got to have critical lab values at you and do dialysis. It's not like going to the unit, you know, you come in with your bag and your earphones, right, and your blanket, and you think you're going to fix your chair up and sit down and plug up to the TV. They may not even have no TVs in there. And it may not even be a chair, it may be a bed. And you thinking you're going to get treatment. They're going to give you the bare minimum treatment. What if you come in there like 3 over, like you do at your regular clinic, and they set you for 3-4 liters like they normally do? They're not going to do that in the hospital. They don't know you like that. You know, God rest his soul. I knew a kidney warrior not going to mention his name, but I met a young lady who was a friend of his sister's, and she called him his brother on Facebook from a Facebook group. And she was a social worker. And she knew they got to be on dialysis, right? Excuse me. The guy, I was able to talk to him, and he shared his story with me. And this is what he said. He'd been going to this dialysis facility for about 10 years. So they know him. 10 years. And you had a new person come in. You know, dialysis clinics always had people coming and going. So they had a new staff member fresh off the boat. Don't know shit. Behind their ears. Wet behind their ears. Excuse me. This person wasn't setting his machine correctly. And he wasn't taking off the right amount. So when he was going out, leaving out, he was wondering why he wasn't getting down to his weight. So then one treatment, he seen it. And he said something to her. And apparently they got into some type of verbal disagreement, altercation, right? And apparently the guy was having a seizure or a stroke when he was going through and saying what he was saying. Maybe he was saying these threats, but I don't know. It's still unclear. But they called the ambulance to come get him. This happened in the unit. And when he was about to get discharged, he said they told him he couldn't come back. Okay? He couldn't come back to the unit. And he couldn't figure out why. And they told him. And so now this guy was one that had a lot of fluid on him. He was a big guy. So he wasn't getting all the fluid taken off, and he was having issues going to the hospital, getting his treatment. Make a long story short, all right, this guy died from cardiac arrest. He was going to the unit for 10 years. They knew the guy. Why you didn't talk to him? Why you didn't have a meeting set up, put him on a contract? Why did you just have to discharge him because of what happened? He was having a medical emergency. All right. Now, I want to take you down. Let me pull it up. I want to take you down the procedures of what's supposed to happen. Okay? Involuntary discharge. I'm reading from Involuntary Discharges from the Dialysis Unit from Christos Argopoulos on slideshare.net. All right. Now, this is from May 16, 2019. All right. And it's a slide. And it's a presentation about involuntary discharges from dialysis unit. Again, something that a lot of people don't talk about or probably don't care to listen or want to know about because it doesn't happen to them. And until it happens to them or their loved one, that's when they want to get the information and know what the hell happened. A lot of people keep their mouth shut because they don't want to rock the boat. They may see something at the unit and don't want to say nothing. Now, involuntary discharge should be the last resort in managing difficult patient situations. Even when it's done it is not always appropriate. Okay, now they got conditions for coverage, Medicare, and I want to talk a little about that. Involuntary discharge requires appropriate documentation and intervention before it is implemented. You just don't go kick a person out. You got to document and try to resolve, remediate, okay? Depending on the circumstances. Now, check this out. It is the medical director's responsibility to oversee all IVDs, which is involuntary discharges. The medical director, he has the last say-so. That's maybe your kidney doctor. Okay, that's the medical director, excuse me, of the dialysis facility. He may be the one that brought you into the facility. Now, that's the one you need to find out what's going on. All right. Also, there's about 17 or 18 network they call end-stage renal disease network. And they're supposed to also advocate on your behalf, but they don't do nothing really. It says the network can help in managing difficult patient situations before they escalate to involuntary discharges. Okay, now if you didn't know this, right, patients' rights in the IVD, all right, be informed of the facility's policies. You got to know the policies. If they didn't tell you that, they could be cited. It's your right to be informed of the facility policies for transfer, routine, or involuntary discharge and discontinuation of services to patients, okay? If this does not happen, the facility will be cited. You can call the state. Also, it's your right to receive written notice 30 days in advance of an involuntary discharge after the facility follows the involuntary discharge procedures. So let me tell you guys something. Where is it at? Let me tell you some of the reasons why they may want to involuntary discharge you, okay? So what happens again? It's shocking then that in the United States, it is estimated that over 1,000 patients excuse me, annually are involuntary discharged from their dialysis clinics. Further, the consequences for such patients, predominantly African American, are dire. A patient may be unable to find a local clinic that will accept them, thereby being required to travel great distances to receive their thrice or 3 times weekly dialysis. Now check this out. Some end up visiting hospital emergency departments where they will receive only dialysis when in extremis. Others die. This healthcare practice, the involuntary removal of substantial number of patients each year from the treatment that sustain their lives, is without parallel. But no one's talking about it. Now look, okay, the provider organizations, this is how they defend their actions. They say the patient has no insurance. However, this is rare occurrence in a system in which most dialysis costs are paid by Medicare. All right. And in a just healthcare system, if a patient cannot pay, should this ever be a reason to terminate care? I got my TikTok crew over here, and I'm asking you guys that. In a just healthcare system, TikTok, if a patient cannot pay, should this ever be a reason to terminate care? Let me hear your comments, TikTok. So look, here's another one. The patient does not follow medical advice. Should the presence of one serious chronic disease ever deprive a patient of life-preserving care for another chronic disease? No, I'm sorry. The patient, okay, I read the wrong one. Let me back up. The patient does not follow medical advice. In a healthcare era focused on patient-centered care, patient engagement, and joint decision-making, could this ever be a valid reason? Okay? Because the patient does not follow medical advice, they may not agree with the doctor. Again, in a healthcare era focused on patient-centered care, I'm focusing on my care, patient engagement, and joint decision-making, could this ever be a valid reason to involuntary discharge a patient from kidney dialysis? All right, another reason that they defend their action. The patient has a mental health disorder. Come on. Should the presence of one serious chronic disease ever deprive a patient of life-preserving care for another disease? I'm asking you guys that share this live. Share this live, guys. This is information that needs to be talked to, a dialogue and discussion that is not talked about in the kidney space. A lot of times you hear people advocating for kidney transplant or sharing someone's story or whatever the case, and there's nothing wrong with that. But when are we going to talk about the tough subjects, the tough topics that go on that no one talks about, like the involuntary discharge, just like this young lady? What if she doesn't find a dialysis clinic? What's her future going to be like if she doesn't get a transplant and doesn't find a clinic? What happens then? She has a family as well. Her life matters. Here's another one. The patient is violent and is a risk to other patients and staff. In reality, reported incidences of serious violence perpetrated by dialysis patients are rare. Most violence is verbal, precipitated by personality conflict based on cultural differences, low health literacy, and poor communication. These are addressable issues. Let me repeat that, because we have thousands of patients that fall into this category. Here's how they justify they want to get rid of you. The patient is violent. He's violent and is a risk to other patients and staff. Yes, I hear what you're saying, my friend, I see your comment, but I'm doing the show. Hit my inbox and I would address you personally. I'm doing the show. I see your I see you on. I'm doing the show on involuntary discharge. In all due respect, if you send me an inbox, I'll get it and I will address you personally. Okay. So anyway, another one that they would say is the patient is violent and is a risk to other patients and staff. Again, in reality, reported incidences of serious violence perpetrated by dialysis patients are rare. Most violence is verbal. All right, I'm gonna kick your ass. I'm gonna bring my family up here to check you. They may mean mug you or whatever. All right, but again, because of that, most violence is verbal, precipitated by personality conflict based on cultural differences, low health literacy, and poor communication. And all these are addressable issues. Here's another one. The patient is disruptive. When this reason is explored, it often turns out that the patient has expressed quality of care concerns. Labeling the patient as disruptive and involuntarily discharging him or her is a form of retaliation. Patients understand the ability of dialysis centers to do this. A lot of patients this happened to. Retaliation. And many describe feeling intimidated, captive, and vulnerable. All of the above is well documented. Everything I went to is documented. You can find it online. You can go to Home Dialysis Central. They got topics on this. Patient complaints, documented their complaints and the reason why they got discharged. It says all of the above is well documented in the public domain. Investigative journalists have published exposés. Patients have told their stories online. Legal opinions and summaries of legal actions have been published. Physician associations have been laminated the practice of involuntary discharge and have published voluntary guidelines intended to limit it. Bloggers have raged, yet the practice continues, as does the human suffering it engenders. What do you tell someone who gets a letter that they had to find a dialysis unit within 30 days? How does that make one feel? Okay, you got to find another facility. You've been going there 5 years, 6 years. You thought everybody was cool with you. Next thing you know, no one's talking to you. They're putting you on. They're not engaging. All because maybe you had a legitimate complaint. How about someone stuck you new and you told them to stop? They was digging in your arm. You was like, stop, take the needle out. And they kept on digging and say, I can get it, I can get it. And the next thing you know, they infiltrate your arm. And now you got this big swollen hematoma. And you told them to stop. I told your monkey ass to stop. Now they can't use your access. You can't get dialysis that day. What if it's a Monday? and you got on 3 liters. What do? You can't breathe. But they can't stick you because your arm is infiltrated. What do? Do you shut the hell up and keep your mouth closed, zip it, and just deal with the pain and chalk it up as, oh, it just happened? And they know the person's new. I mean, what do you do when you have a needle this size, somebody brand new sticking you with a needle this size, and you tell them to stop digging, and they keep on going, thinking they can get it, and they go through your arm, through your access with that needle? You just don't say nothing? Because if it was me, I want to say something. And should that, because you said something because someone infiltrated your arm, you told them to stop, go get somebody with more experience, and they didn't listen. Now the next thing you know, your arm is infiltrated from a 15 gauge needle. You're not supposed to say nothing. And then when you do, and you carry it further, they want to say you're being disruptive. You're being disruptive, but somebody just effed up your arm. I'm supposed to just sit back. Okay. Oh, doggone. You messed it up. Now, you got some patients who are forgiven. Okay? You got patients like that. You got, people like that know that we all make a mistake. But what if the person make a mistake and they arrogant about it? They arrogant and try to turn it and flip the script. They try to spin it and make it look like it was your fault. Oh, your access is too deep. You moved your arm. Hold still. That's what you got to watch out for. Okay? And so they go on to say involuntary discharge from dialysis, and we know dialysis is a life-sustaining treatment, is a uniquely American phenomenon. It is not reported with any frequency in other first world countries. In Canada, as just one example, it would be impossible. In Canada, it would be impossible to involuntarily discharge a dialysis patient from a treatment center. Accordingly, this phenomenon offers key insight into the American healthcare system and into the professional behavior of some of its practitioners, insights that are important at a time the system may be further privatized. And check this out. Why uniquely American, over 80% of dialysis care in the U.S., care that costs Medicare over probably $100 billion annually, is provided by 2 for-profit public companies. We all know they Fresenius and DaVita, okay? Creation of shareholder value is the driving force of these companies. Let me repeat that. Why uniquely American? Over 80% of dialysis care in the U.S., care that costs Medicare, over 50 billion, maybe up to 100 billion or more annually is provided by two for-profit public companies. Creation of shareholder value is the driving force of these companies. In fact, one of these companies, probably DaVita, has proclaimed that, and I quote, "The business of my company is not about patients," end quote. So shortcuts in dialysis staff training and supervision may add to the bottom line, but may also contribute to the phenomenon of involuntary discharge. And embedded in the CMS remuneration system are financial incentives beneficial to these companies that may explain why they allow this practice to continue. So what can be done? What can be done to stop this? A number of opportunities exist that, taken advantage of, will result in meaningful change. The accountability framework within which providers of dialysis care in the U.S. operate requires strengthening. The Center for Medicare and Medicaid Services, CMS, funds a system of regional end-stage renal disease networks. Among the purposes of these organizations, providing assistance to ESRD patients and providers, and evaluating and resolving patient grievances. In the matter of involuntary discharge from dialysis, dialysis patients' advocacy groups have compiled abundant documentation confirming that the ESRD networks typically provide little meaningful patient support at a time of involuntary discharge. Meanwhile, CMS refuses to ensure that ESRD networks are held accountable in meeting their prescribed responsibilities to patients. Now, basically, no one's doing shit. Okay? No one's doing nothing. Because if that was the case, we wouldn't have 1,000 patients being annually discharged each year involuntarily. No one is saying nothing about this. You don't have no big kidney disease education organizations saying anything or talking about this. They got the bigger platforms: AAKP, National Kidney Foundation, nationalkidney.org. All these big organizations had the platform to address this situation, but haven't done so. When are we going to start putting patients over profits? When will we start doing that? Looking at patients over profits? We know the bureaucracy, the people who control the money, the people at the transplant centers, the nephrologists. We know that chronic kidney failure is a serious disease. In fact, it's so serious, it's the 9th leading cause of death in the United States. And when that disease progresses to end stage, when you get to Stage 5, when your kidneys no longer function, where they're able to remove the fluid and the toxins, you may still have little urination, but not enough to remove the amount of fluid you need to remove and amount of toxins to survive. That's going to require dialysis to sustain your life. Now, if they involuntary discharge you on some bullshit because you calling them out on that BS and they want to label you disruptive, now they're playing with your life. You can't go to the DaVita down the street because they all connected. Then they may have called the other facility. You go to a Fresenius, they may take you, but then they may call and find out what's going on. Why they coming over here? Why they transferring? Why they getting kicked out? And they don't have to accept you. That's the thing about it. That's what makes it so hard. The clinic doesn't have to accept you. What if you got a mental condition and you zapped out on somebody at the clinic and you didn't mean to, but it's a mental condition? That's a chronic condition. Then what? Now they're going to stop one treatment because another condition reared its ugly head. Because maybe that person, the staff member, was being careless or reckless with your care. And you called them out on it. You pulled their card. And now you're the one that has the problem. This happens so many times. I can't tell you how many times I've seen this in my career. And again, no one's talking about it. I'm the only person that's talking about it. Other than you Google it, you'll see articles on it. You can Google involuntary discharge of dialysis patients. You see a whole slew of stuff. But no one's thinking about that. But what happens to the 1,000 kidney warriors? The brothers and sisters who are dealing with the same disease we are, because I have stage 2. What happens to them when they call them out and then they get involuntary discharge? They don't go through the process. Okay, and there is a process. And I want to read that process. The involuntary discharge process. The IVD starts with the medical director. It starts with him or her. Whoever is the medical director of the dialysis facility, it starts with that person. Okay? Who ensures that the interdisciplinary team documents the reassessments, ongoing problems, and efforts made to resolve the problems in the medical records. 2, provide the patient and the local ESRD network with a 30-day notice of the planned discharge. 3, obtain a written physician's order that must be signed by both the medical director and the patient's attending physician, concurring with the patient's discharge or transfer from the facility. Contacts another facility, attempts to place the patient there, and documents that effort. 5, notifies the state survey agency of the involuntary transfer or discharge. Okay, that's how it's supposed to go, but it doesn't always go that way. And when a nephrologist discharges a patient, if the facility for replacement, then the patient cannot be involuntary discharged. Okay? You got to find a replacement. You can't just discharge a patient and the patient doesn't have a doctor. If the facility cannot find another nephrologist who will care for the patient in the facility, the patient must be discharged or transferred to another facility. Wow. In these situations, the clinician who refused to provide care must avoid medical abandonment. Inform the patient they will no longer provide care after a reasonable period. Make a reasonable attempt to place the patient into another clinician's care. Reasonable behavior standard. What a reasonable person would do under the circumstances. Now, the social worker plays a role in this as well. All right? And you may find her trying to duck and dodge the situation. Who knows? I mentioned that to the young lady I did the stitch on who'd been discharged. She said the social worker didn't do anything for her. Now, preventing involuntary discharge, the role of the social worker and the interdisciplinary team. Patients are to be assessed at least monthly when they exhibit significant changes in psychosocial needs, patterns of disruptive behavior, abusive language, physical harms or threats of harm, brings weapons or illicit drugs in the dialysis unit, patterns of non-adherence to recommendations, which is highly likely to lead to conflict with staff and disruptive behavior. Now, let me tell you something. Number 2, patterns of disruptive behavior, abusive language, physical harm, and threats of harm, bring weapons or illicit drugs in the dialysis unit. Now, let me tell you, there are patients that do need to be immediately discharged, but you need to address that quick, find an alternative method, because you got patients, let me tell you, I work with patients who got off the machine, went into the bathroom and sparked up, went in there and smoked crack or shot up dope. I know patients who have brought weapons to the facility and kept them in the bag. I've known patients who cuss staff out. In fact, I got cussed out. Patient went to go give a patient medication that the staff told me they wanted. Patient told me to shut the F up and get the F out of his face. And I'll say, okay, you got it. So that type of behavior is not acceptable. I'm doing well. That type of behavior is not acceptable when patients want to threaten you, call you out of your name. All kind of stuff. But there's a way to address this, okay? There's a way to go along about this process. And, if not, a patient could possibly die going through this process, okay? So let me say this. Let's talk about the concepts for understanding non-adherence, meaning patients may get off dialysis early or not come to treatment or not go along with the treatment suggestions of the physician. But it says, one, patients had a right to refuse treatment. Ethical principles of autonomy. You had the right to refuse dialysis if you do not want dialysis. Or if you want to get off dialysis, you on the machine and you don't like something, you see something you don't like in the facility, something unsafe, and you want to get off, and you only been on dialysis 2 hours, 2.5 hours, you had that right to get off dialysis. They have you sign an AMA. All right. 2, the provider has no, listen to this. The provider, it could be DaVita, Fresenius, whoever. The provider has no statutory authority to deny treatment to non-adherent patients. Again, the provider has no statutory authority to deny treatment to non-adherent patients. Legal cases related to non-adherence and IVD. Payton versus Weaver, 1982. Brown versus Bauer, 1987. Both cases characterized by significant disruptive behaviors toward other patients, facility staff, and physician in addition to non-adherence. Both patients were IVD for disruptive behaviors, not for their non-adherence. Okay? Failure to comply with instructions of the dialysis staff does not qualify as disruptive behavior. All right? Failure to comply with instructions of the dialysis staff does not qualify as disruptive behavior. Non-adherence may signify changes in needs that should be used as red flags to devote resources / investigate the needs of the patient. The needs of the patient. You got somebody who just maybe started dialysis that may have some maladaptive behaviors to this because it's new. We know chronic disease can cause mental illness. People try to deal with this situation. Hey, Lady Coco, thank you for joining. See, I'm not always in front of the dialysis clinics, but it's about education. That's all. I don't want to shut the clinics down. I wish they could close some, so, out of these communities and put them in the medical centers. But anyway, non-adherence may signify changes in needs that should be used as red flags to devote resources / investigate the needs of patients. 1, grievances, painful treatments. And I talked about that with these needles. If you sitting down in the chair, your mom, your dad, your loved one, right? You sitting down and someone new to dialysis is trying to stick you in the arm and they can't get it, and you tell them to stop. You tell them to stop and go get somebody with experience, and their pride won't let them, and they being arrogant and still sticking, saying, I can get it, I can get it. And next thing you know, they infiltrate it, or they put it in there and they get mad at you because you want them to go get somebody else. So now they're directing their anger on you because they couldn't stick you properly. What the fuck? I mean, I seen it. So you got painful treatment. You could be cramping. Anything could be going on. Adult care schedule conflict with your job, your work. You know, they may not, you know, be able to accommodate your work schedule. So you may have to cut treatment or be late just to get to work. You still got to get paid. Work schedule conflicts, travel problems, inadequate understanding of consequences, the need for education, cultural context for the behavior. All right? And we know, let's just keep it how they say, a stack. We know if you go to a clinic that is predominantly Black and they got white staff, right? You may have some conflict differences. That's just the cold hard truth. You may be, you know, you may have people being nice, but then you may have some staff that may bear from their past, could be racist. You know, that undercover stuff. I shared with you guys the lady in Texas that put bleach in patients' line and killed 5 Black patients. She was white. I'm not trying to make it about that. I'm just delivering the cold hard truth that in some states this stuff persists. We don't want to talk about it, but we do. And that's where the cultural context for the behavior. You may have someone's Black and someone's white that's sticking them, and they infiltrate, and the person that's Black may think they did it on purpose. Maybe because after they did it, they talking to a staff and they bust out laughing. Who knows? You know, perception is something. You see somebody laughing or smiling, you undergoing this treatment, and your arm is swollen, and you feel like they're not acting or moving fast enough to deal with it. You know, you may feel mistreated. So look, how are we going to prevent involuntary transfers or discharges? Useful things to consider in your facility to prevent IVDs. Acute unstable care plan meetings when behavioral red flags are detected. 2, behavioral agreements or contracts. 3, mental health services referrals. 4, pay attention to simple stuff. Dialysis time shift, change in transportation arrangements, Social Security checks, assistance with copays. 5, implementing decreasing patient provider conflict toolkit. 6, talk to the network. Okay. The nuance of contracts can be used to formalize an agreement with consequences to both sides in the event of failure. Provides a written record of a mutual agreed upon solution. Cannot and should not be used as a prelude to IVD. CMS and the ESRD networks will provide will promptly discount the value of the contract. It will not protect the facility from negative legal or regulatory consequences. And then they, conflict resolution model. They talk about, decrease conflict between patients and staff, create a calm environment, open yourself up to understanding, need a non-judgmental approach, focus on the issue, look for solutions, implement change, continue to communicate, take another look. So, as I wrap this down, this topic is very, very serious. And if you're watching this and you go to dialysis, your parents go to dialysis, make sure you go back and look at your patient's rights and responsibilities. Look at your grievance procedure. It's supposed to be posted up on the wall in the patient's lobby of each facility. Even when you are admitted to a dialysis clinic, they're supposed to patient's rights and responsibility, your right as a patient, what they supposed to deliver, and the grievance process, if you have a problem or complaint, what they want you to do. But you always had an option of calling the state, your state regulatory. If you got a problem, call the state. Because some clinics may try to resolve it, some may not. They may just brush it under the rug or brush you off. You can't find the facility administrator. They may not always be there. They may give you the runaround. So always call the state if you got a serious issue. All right, let me look at some of these comments on here. Oh, hey, my work buddy, Sanika Nash. How you doing, friend? Hope you enjoyed the broadcast. Guys, this is going to have to be another show because I could go on another hour talking about this, just answering questions and talking and commenting. But I got a 3 o'clock wake up to go to work. She said, I made a post to get others to join. Thank you. Thank you, Echo Spirit. This is an aspect that I had never thought of. Yes. No one thinks about this. We work in dialysis, and a lot of staff work in dialysis, and we see patients, and we got tunnel vision, and they may have an issue. They could be having some problems at home, and then they come to dialysis and may take that problem out on you. I don't take it personal anymore because we don't know what someone got going on outside of dialysis. And you come in, and if you're not on your best professional behavior to kind of de-escalate or communicate, you got to have empathy, compassion, communication. It takes all of that, a combination of that, to work with patients with ESRD because there's so many dynamics that you have to address when it comes to this disease. Margaret Howe, thank you for joining, Margaret. I've been on dialysis for a month. DeVita, not good, but what can I do? See, Margaret on Facebook commented. She's been on dialysis for a month. DeVita, not good. But what can I do? You can transfer. Find other facilities. I'm not sure what state you're in. Go before don't even say nothing to your facility. Just go to your facility, do what you're supposed to do. But outside of that, on your days that you don't go there, find another facility. Go look for Fresenius or a US Renal or a renal care partner or another, Google another dialysis. And if that's not the case, where it may be a monopoly in your area, try to find a nursing home unit that accepts outpatient. A lot of times these, and that doesn't have a DaVita there. A lot of times these nursing home units accept outpatient, and they ran by small independent companies that provide superb care. They just on a smaller scale. Okay. Also, what you can do, most importantly, look at your treatment options. Maybe this may be a way for you to go home and do home dialysis. Maybe seek CAPD or home hemo. There are companies that are out there that will perform home hemo for you. You just got to do your research. And don't worry about your doctor upsetting them. This is your life we're talking about now. Find a doctor. If you're not happy with your physician, your nephrologist, Google a nephrologist in your area that works independently. Because you got nephrologists that don't affiliate themselves with these large companies. And look at their score. They got a medical score, and people complained about them or whatever. That's what I would do, because a lot of these doctors, these big practices, affiliate themselves with these large dialysis group corporations. And so, please, if you don't feel safe, make sure you know your treatment, like your orders, like how much heparin you get, your medication, with your dry weight, your blood flow rate, how much fluid they're taking on. Make sure you know your prescription so you can hold these people accountable if someone new comes in and they don't have you set right. Let's see, True Spirit says, True, you are the only person I have ever heard talking about the problems patients who are involuntary discharge go through. Yes, nobody wants to talk about this. I don't know why. It happens. Kidney warriors pass away because of someone else's perception most of the time. Yes, we do have patients that are disruptive, but we got to find what's the issue behind it. Why are they disruptive? A lot of times they're angry because this disease got a hold of them. How do we treat or help them deal with the mental aspect of this disease? Margaret says, patient attending physician has no concern. If I went to another facility, I don't think it would be any better. I haven't even gone to discuss anything with social worker. Don't think anything will change. And more than likely, nothing probably will change. And I'm so sorry to say that. It's unfortunate. And I bet you a lot of patients feel the same way you do. They don't get no help from the social worker. Just imagine if you have 100 and something patients that go to a dialysis facility and the social worker is covering all 100 something patients. They're overwhelmed. They just want to get through the day and get out of there. But I really think if you go to another facility, it could be different. Not all dialysis clinics are created equally. Okay? Even though the corporation is trying to get the bottom line, a lot of times in the facilities, it's the staff like myself, the line workers who make that difference. The ones that is holding your hand when you're getting stuck for the first time. I'm holding your hand, telling you it's going to be okay. You don't have no CEO or no bigwig in a suit sitting on the floor doing that. That's what makes the difference. The people and the personality that are in that facility that's delivering your care are the ones that make the difference. They're just following the rules. So I think it will make a difference if you try to do home dialysis or seek another facility. Just go and look at it. Maybe talk to the patients in the lobby and ask them. Margaret says again, I did dialysis on another shift last week. 2 patients cursed out staff. Wow. See, this is real. This is real. 2 patients cursed out staff. One morning we couldn't get in building. No RN was on staff. Waiting almost 3 hours. I believe that, Margaret. I believe that. This is the thing that a lot of people don't know in dialysis. This is how important registered patients cannot, I repeat, patients cannot start dialysis until there's an RN in the building. So tomorrow I work on the Eastern Shore. I got to be there 5 o'clock. I live in Washington, D.C. About an hour and 15-minute drive over the Chesapeake Bay Bridge. If I oversleep, right? I got my alarm set for 3 o'clock. Once I finish this, I want to get my scrubs and stuff ready and take my shower. If I oversleep and wake up at 4:15, 4:30, it takes me an hour and 15 minutes to get there. I'm not going to get there at 5. They can't do nothing. Nothing until I walk in that building and check that water, that chlorine and chloramine. That's how important I am. Now, you would think other nurses who know they had that responsibility would had the same mind thought. But some people just don't give a damn. I get there when I get there. And who suffers? The patient. They suffer. So this is ridiculous that Margaret and other patients had to wait 3 hours for a nurse to come in, and then when that happens, they want to cut your treatment. They want to cut your treatment. Then they want you to sign the AMA. We got to cut your treatment, but it was your fault. And let me tell you, if you go to dialysis, your parents, and you start late because of the facility's fault, maybe the water system is down or the RN is late or whatever, they have to run you your time. And here go Margaret. She even said it. Right, cut treatment. I did not let them. Don't let them pour that bullshiggity on you. If you find yourself in a situation where normally you go in and you start at 6 a.m., but now you're sitting out in the lobby, all the patients are sitting in the lobby, some standing up, y'all sitting around waiting, talking, like, what's going on? Here it is, 6:15, 6:30. Now the damn soul came out to the lobby to tell you what's going on. Suddenly, you got one patient going to the door, and we had staff there around. Damn, who that knocking like that? It sound like the police. And they just want to know what's going on. What's going on? Like the other day, last week, I was at work. I was at a facility, 24-chair station facility, located inside of a nursing home. That shows you how big this problem is of kidney disease. 24 freaking chairs inside of a nursing home. Operates 6 days a week. 3 shifts on Monday, Wednesday, Friday. 2 shifts on Tuesday, Thursday, Saturday. Come in, go back to check the water. Nothing's coming out for me to test. What's going on? Next thing I know, the booster pump is not working. The pump that pushes the water through the system. What happened? The water pressure dropped in the community, thus lacking water pressure to us to do dialysis. Patients had to wait 2 hours to go on. A lot of patients cut my time. No. I want to get. You have to offer them their time, regardless if it's going to push back second shift. But a lot, just like Margaret says, they started 2 hours late. Then they want to cut your treatment and have you sign an AMA. Don't let them do that. You run your time. It's their fault. If you came late, if it was your fault, they could cut your time. If it's your fault, if you're supposed to be there at 3 o'clock, you get there at 4 o'clock, and you 4 hours, they're not going to run you to 8 o'clock. They're going to cut you off with the last patient. Come in 4, last patient get off at 6:30. Guess what? You coming off at 6:30. They may extend the time if they're nice enough. So an AMA is against medical advice. It's against medical advice. It's a piece of paper that they have you sign. Like, for instance, if you want dialysis and the doctor writes an order for you to have 4 hours of treatment, and say at 3 hours and 15 minutes, say you got issues with anxiety and you just feeling, or you got some restless leg syndrome, or you just got to get off at 3 hours and 15 minutes. You can't take it no more. You can't do 4 hours today. I want to come off now. Okay, we can take you off, but here, you got to sign the AMA. And basically the AMA is to absolve the facility from being liable if you go out, you get off early and you didn't go to prescribed treatment, and you go out and you have a heart attack when you leave. It doesn't hold the clinic liable because they took you off early and you didn't get it. Hey, Nephro MP, thanks for joining. What I was talking about, the original conversation was involuntary discharge of dialysis patients. Again, 1,000 patients are involuntarily discharged each year from dialysis. And the reason this conversation came up again, I talked about this before. This came up as a result. I did a stitch on TikTok of a young lady who said her medical team dropped her case, and she's looking for a living donor. She said the reason why they dropped her case because she put a malpractice suit on because somebody messed up on the injury during surgery. And so, hey, what's going on? Drop one. But, it goes on both ends. Of course, if a patient is disruptive, bring in a firearm and want to threaten people with the gun, talking about, I'm going to shoot you. Yes, they want to have to get that person out. But for someone who has a legitimate complaint, right. Yes, like the MP says, for my practice, it has to be a big behavioral problem to be discharged from a. Yes, and then you're going to, put them on a contract when you first see this behavior taking place. You're going to address it, and first you're going to talk to them, and then they do it again. It's going to be a second one. Then it comes to contract. Yeah. And so we have a lot of patients that are being discharged each year, 1,000 or more. And what happens, unfortunately, they can't even go, some of them can't even go to the facilities in their community because the clinic they done got wind that this person's been involuntary discharged. Patient's going to be labeled as a problem patient. They don't have to accept that patient at the other facility. And next thing you know, patient may have to go to a clinic 20, 25 miles. Yeah, 20, 25 miles away. That is like, how you going to get there? And the MP, BLM 1971 says some patients have burnt all their bridges. I've seen that as well. I mean, you do have patients who they just straight, excuse my expression, they straight ignorant, and they don't give two F's, and you got patients like that who are just mad at life. Maybe they may got HIV, chronic kidney disease, Hep C, just mad with the world. And they want to make it hard for other people as well. Now, I've had patients, and I'm not exaggerating when I say this, back in the late 80s, early 90s, I had a patient that was HIV that poured out their needles. They didn't care. And what you going to do, you a staff member, and this was just like when kind of AIDS was coming out on the scene, and it was out there, but still not enough education about it. And we got on face shields, double gloves, double masks. And here you got somebody standing up and blood squirting out, and they won't even let you get in there and stop the bleeding. I mean, you can't have nothing like that happening again, because you clearly put other patients and staff in harm's way. So you do have some patients that there's not no coming back from their behavior, and it's under pressure and goes everywhere. Yes, absolutely. If that needle, that arterial needle is coming out, I got a fly flying around in here. But yeah, guys, I'm going to end. I want to stay on my TikTok for a moment, but I'm about to end the official broadcast. Thank you guys for tuning in. Share this broadcast because, again, this topic needs to be talked about. Okay, we got 1,000 kidney warriors being involuntarily discharged from the dialysis center. Whether it's legitimate or not, we can't have this. There has to be some other remedy or options that can mitigate this. Okay? So, yeah, I was having flashbacks. So with that being said, I'm going to end the official show on my YouTube and Facebook page. I'm going to continue to talk with on my TikTok live for maybe about 5 or 10 more minutes about this topic and address some of their comments and concerns and go from there. Let's see what Margaret says. Oh, you're welcome, Margaret. Hit me up anytime on my in my inbox if you have any questions or concerns. In my inbox on Facebook, and maybe I can give you some ideas or anything else you can do to get out of that situation. And again, thank you for your support on purchasing my book. I hope it kind of prepared you for dialysis. And for those of you who are watching, don't know what I'm talking about this book that I wrote, How to Survive Outpatient Hemodialysis, a guide for patients with kidney failure. This book is designed for anyone who wants to know about dialysis, but most importantly, if you, your mother, your father, or family member, friend, loved one about to start dialysis, this gives you an in-depth look on the insight on what to expect on that first day of dialysis. Okay. The foreword is written by Ken Souther, who is a pediatric nephrologist, and he's also a kidney warrior himself. And also Charles Bonner, who is a civil rights attorney that was on the Pettit Bridge Bloody Sunday, and he wrote his forward from a civil rights perspective on healthcare. So you can get this book at my website, www.stevethekidneynurse.com. Very good book, 150 pages. It's an easy read. And in the back, I have a glossary, right, of common words, resources of smaller organizations that are making an impact in the kidney space, not the large organizations who are spending millions of dollars and are not doing nothing. Thank you, Margaret. Margaret says the book is a great help, very informative. It is. It's very informative. It's not like it's on a New York bestseller list, but it's very informative. It's worth the money for anyone starting dialysis, that new normal, that's afraid, the unknown. This book is going to take you into the unknown and what you're going to see on your first day. So with that being said, thank you, Margaret. Like I said, if you have any concerns or questions, just reach out to me on the my Facebook inbox, and I'd be more than welcome to answer any questions. With that being said, guys, thank you for joining me. Stay tuned for another broadcast, possibly next weekend. I got to work every day this week. It's going to be one of those weeks. But with that being said, take care. God bless. And follow Steve, the Kidney Nurse. Follow the Warriors Quest Show, Urban Health Outreach Media. We on the move. God bless. Stay blessed and encouraged. Peace.
All these brothers, my guys, know that they fly, know that they ride or die. I keep waves by my side, CJ Ike, now I gotta roll with ice. Cold, these brothers, my guys, know that they fly, know that they ride or die. I keep waves by my side, CJ Ike, now I gotta roll with ice. Ride or die, 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 ride or die. Cold, these brothers, my guys, know that they fly, know that they ride or die. I keep waves by my side, CJ Ike, now I gotta ride or die. Around, don't get caught in the mosh pit. Fuel to the fire, ain't nobody can stop it. Trouble in my city, but you know I'm across it. Got a 40 on my hip and I'm liable to spark it. Throw down these hits, my click is indivisible. I aim, you duck, I squeeze, now you invisible. I'm not afraid of getting physical. All these different chemicals are fogging up my visuals. Bloods on my hands, got slugs on my gunners. Yo, we notorious, we ain't no runners. Bloods on my hands, got slugs on my gunners. Yo, we some warriors, they ain't called gunners. Bloods on my hands, got slugs on my gunners. Bloods on my hands, got slugs on my gunners. Put on my sweat, put on my beam, put on the map, put on my team. Take out every motherfucker in between. Know what I mean? Better myself, better my aim, better my rap, better my name. Killing rappers on my hang, I'm by their chains for the fame. Never thought I would, and now I'm running. You don't wanna follow me, now I'm fucking running.